When you're using your microscope every day, you should be also doing maintenance on it every day to make sure that it stays in working condition. So one of the best things to do is to get all of the dust off of it. So I'm going to use a can of air and very gently just brush the dust off of the body of the microscope. I'm also going to brush the dust off of the condenser lens on the bottom, very gently the ocular lens as well. Because a lot of dust can collect there. Alright, so now that that's done, I'm going to clean each of the lenses. I'm going to use a little bit of distilled water on a cotton swab. And I'm going to gently, from the center to the outside, just gently wipe off anything that may accumulate on the eyepiece and the other lenses. I'm then going to take a dry one and dry them off. Now to repeat the process for the condenser lens down here. And you can turn the light on for this one, that way you can see it. And last but not least, ocular. And then the last thing that you would need to do for this machine is to actually wipe off the objectives. And in order to do that, you would need some lens cleaning tissues. And I would only use this if you've used immersion oil on the highest objective lens, which is 100. And you don't want to rub, you just want to dab off that oil very gently. That way it's ready to be put away. And the enzyme-linked immunosorbent assay test that I'll be running is a heartworm test, so I have my supplies here. I have my blood. So it takes 3 drops of blood. 1, 2, 3. It takes 4 drops of the conjugate. The way I remember is red has 3 letters and blue has 4. 1, 2, 3, and 4. So I'm going to mix that up, invert it a couple of times. And then this I'm going to pour into our heartworm testing well. Once that reaches our activation window, I will press down and then wait 8 minutes for it to incubate. Now that our test is incubated for 8 minutes, we can see our results, and we have 1 blue circle at the top, and that means that our dog is heartworm negative. The modified Knots test is used to help concentrate microfilaria that is found in the blood so that we can see it. This test can also help differentiate between Dirofilaria and Acanthocheilonema, a couple different species of the little worm. So what we need to do is I have 2% formalin here, and we don't have a bucket centrifuge, so I'm going to split it between 2 no additive containers, centrifuge tubes. So I'm going to place half of it in one, and the same in a second. So this is my formalin, And then I have 1 cc of blood from my patient. So I'm going to put half a cc in this one. And half a cc in my second tube. I'm going to invert and mix these pretty well. Now that my sample has incubated at room temperature for a couple of minutes, 1 to 2 minutes, and have been centrifuged for 5 minutes, I can take my sample and pour off the supernatant very carefully. And what I'm left with is red blood cells at the bottom. So what I'm going to do, I'm going to take a drop of the new methylene blue and use 1 to 2 drops in the tube. One nice big drop. I'm going to mix it with my pipette. And then I'm going to take a drop of this and place it on a slide that I have here. Cover it with a cover slip, and we'll look at it under a microscope. Currently looking at it at 100 power under the lens, and I don't see any microfilaria. But what this technique does is it concentrates the microfilaria while fixing them, and it also lyses the red blood cells, so you can take a look and see what's going on. And while scanning it, I'm taking a look for any of the microfilaria, the worms, in the sample, based on their body size, body shape, how they look overall. A direct smear is one of the easiest ways to look for motile parasites in the fecal matter. So I'm going to take some fecal matter, place it on our slide with a drop of sterile saline, cover it with a cover slip, and then we would examine it under the microscope. And there is our direct smear. One form of fecal testing is a fecal flotation. So in my beaker here, I have between 2 and 5 grams of fecal matter. I'm going to add 30 milliliters of a saturated salt solution that I actually created here, and I checked with the hydrometer that it's about 1.2 specific gravity. Since we don't normally carry that here at a dental clinic. So with that, I'm going to mix up my fecal matter and salt solution, mix it up really well. Like that. And the purpose of performing the fecal float like this is the parasite ova, when they're introduced into the salt solution, they will actually float to the top. They're lighter than the solution, so they'll float to the top, and we can hopefully catch them on a microscope slide, cover slip. I've mixed that pretty well. I'm going to strain it using a piece of gauze. And since we don't have necessarily a big tube, I'm going to use a regular non-additive white top tube. I'm going to come over by the sink so I don't make a mess. And I'm going to strain my solution through the gauze. Just like that. Get as much in there as I can. Perfect. So I'm going to come back over here. And I'm going to fill it the rest of the way so that I have a nice dome at the top, and then I can place my cover slip on top. And then it'll sit there for 10 to 15 minutes. Once it's ready, I will take the cover slip, place it on a microscope slide, and I'll place that under a microscope and look at 100 power. So now I'm going to do a fecal flotation with centrifugation. This is a little bit more sensitive than just a regular fecal flotation, and it basically brings up a lot more of the eggs and ova a little quicker than the fecal flotation. So again, I have 2 to 5 grams of fecal matter in my beaker. I'm going to add my solution, about 30 milliliters, and we're going to mix it up again to make a nice homogeneous solution. And what we're going to do is then I will strain this into a non-additive test tube. My clinic does not have a bucket centrifuge that I can place a fecal sample test tube in there with a cover slip, so I have to do it a little differently. I have to do the modified version, so I'm going to place some of my solution in a test tube and put it in our angled centrifuge, which will also work. I will just have to leave a little bit of room at the top of the test tube. So now that I have my solution, I'm going to take my gauze, and again I'm going to bring it over to the sink so I don't make too much of a mess. And we're going to fill my tube up while leaving some room. I'm going to put that there, and then I'm going to actually bring it over to my centrifuge. And I already have another test tube with just regular water to balance it. So that is going to sit in here, it's in a centrifuge for 5 minutes at 1500 RPM. So now that my sample has been in the centrifuge for 5 minutes, I'm going to take it and I'm going to fill the rest of the way with more of my solution, my salt solution, to create a meniscus at the top of the test tube. And I'm going to take a cover slip, and again, just like in the fecal float, I'm going to place this on top, and it's going to sit for 10 to 15 minutes, and then I will remove that cover slip, place it on my microscope slide, and I will look at it under the microscope at 100 power and see what I can find. Fecal sedimentation is used when suspected parasite ova are larger than what can be recovered in a standard fecal flotation. So what we need to do, I have 30 milliliters of water in my beaker, and I'm going to take a few grams of fecal matter and I'm going to mix it in my water solution. What I'm going to do next is I'm going to strain it into a 50 milliliter centrifuge tube with a piece of gauze. And there's 2 ways you can go about this. You can centrifuge it for 5 minutes at 400 Gs, or what I'm going to do is I'm going to let it sit for 15 to 30 minutes once it's been strained. To let all of that, the heavy stuff, fall to the bottom. Now that I have a good amount of strained solution, I'm going to fill the rest of it with water. And again, I'm going to let it sit here for about 15 to 30 minutes. Now that my solution has been sitting for about 25 minutes, I'm going to decant off the supernatant, leaving the sediment at the bottom very carefully. without disturbing the sediment at the bottom. And then I'm going to refill it with water. And let it sit again for another 15-30 minutes. And then I'll do this one more time, and then we'll be ready to look at it under a microscope. Now that I've washed and rinsed my fecal sedimentation, I have poured off the last of the supernatant and have very gently mixed the sediment that is left in here, which isn't very much on this patient, and I'm not surprised. So what I'm going to do now is I'm going to take a drop of the sediment and place it on a slide here. Just like so. And I'm going to cover it with a cover slip, and then I will observe this slide under a microscope and look for any large ova.
Urine collection via free catch. Urine is most concentrated in the morning, so it's best to collect a sample in the morning before a meal is given, and then that way dietary factors will also not affect the sample. Since it's most concentrated, it'll make it easier to find any formed elements if they are present. Collection should be made in a clean container. I'm going to use a bowl like this. You can also use a cup taped to the end of a stick. That way, if you're afraid of your patient stopping midstream because you're underneath them, you can be a little bit further away and still collect a sample. It's best to collect a sample midstream to avoid any contaminants that are from the outside on the lower end of the urinary tract. So, all right, Austin, are you ready? Let's go collect a sample. Show you how it's done. So I'm gonna let him come over, let him pee a little bit, and then I just get under there and collect a sample as needed. For cystocentesis, there's 3 different methods of collection. You can perform a blind stick when you can't necessarily palpate the bladder, but you know the anatomy, so you can still go in and collect a sample. You can perform an palpation isolation, where the bladder is distended, filled with urine, and you can isolate it with your hands and collect it that way. And the last one is ultrasound guided, where you visualize the bladder with an ultrasound and perform the cystocentesis that way. So the patient should be in dorsal recumbency, just like Austin is here. And as far as collection method, I have a sterile syringe with a sterile needle. I have 2 different kinds of needles. The first one is for the cystocentesis. It's a 1-inch 22 gauge needle. And then once I have my urine, I'm going to transfer it into the vacutainer with no additive with a 22 gauge smaller needle. I have some prepping sterile gauze here with chlorohex alcohol and some dry. So I'm going to prep the area where I'm going to perform the collection at. Once I'm ready there, I have my needle. And with Austin, it's a little hard to palpate, so I'm pretty much doing this as a blind method. So I'm gonna go in right next to the midline, with the penis is on the side, away from the midline where the bladder should be. Go in and pull up with my syringe as I'm collecting my sample. And I'm going to release the pressure on the syringe to prevent any contamination to any possible contamination into my sample. When it comes to urinary catheters, there's 3 different options that you can use. There's a Foley, which is a longer term type of catheter that has a cuff that keeps the catheter in the urinary bladder instead of pulling out into the urethra. There's 2 other kinds: a red rubber, which is a little more pliable and bendy,
for certain cases, and then there's also a polypropylene, which is the kind that I'm going to use here today, and this is a brand new tube, so it's still sterile. And these are a little bit more stiff as far as plastic catheters go. So for the catheter placement itself, here we have Austin in lateral recumbency, so he's on his side here, doing very well. And my lovely assistant Amy is going to extrude the penis for me. You're doing so good. So good, Austin. Now that is the penis extruded. I'm going to clean the area. That way we're not introducing any germs into our clean, sterile sample. And to keep up with sterile techniques, I'm going to be using sterile gloves. I'm going to open my gloves, and I'm going to create a clean field. So not only do I have sterile gloves, but I also have sterile lube, and this is a brand new bottle. Never been opened. So I'm going to open this up and put a little bit of lube on my sheet. Also my sterile syringes. I'd have two here for the purpose of discarding the first little bit of urine that I get from the catheter. Now for my sterile catheters, I'm going to crack the lid, and I'm going to leave the lid on. Amy's actually going to hold it for me. That way I will stay sterile once I put on my gloves. Get my sterile gloves on correctly. Amy will remove the lid on my sterile catheters so that I can grab one. And these are brand new again. And the first thing I want to do is I'm actually going to measure how far into the bladder I'm going to go. So without touching Amy or my patient, I kind of want to estimate about where the catheter is going to go, how far in. So probably about there. And then with my sterile lube that's still in my sterile field, coat the tip of my catheter. And slowly guide it into the urethra. Alright, here's our urine. Touch my syringe, and I'm going to gently aspirate a few milliliters. I'm going to switch my syringes.
so that I can get a truly clean sample that can be sent out for bacterial testing. Once I have enough, slowly retract the catheter. Such a good boy, Austin. Being ever so kind as to not flick any urine around. For patients that seem particularly itchy in the ears, whether they're shaking their head a lot or they may be pawing at their ears, it's a good idea to perform an ear cytology. And what we need to do, we're going to take a sample from both ears, basically to compare to see what's going on. Now Austin here, he's going to let me look in his left ear. I'm going to take my swab and I'm going to go inside the ear canal, the external ear canal, and just take my swab and gently wipe it around the inside. Good boy. And I have a nice sample. I'm going to take my slide, and on the left hand side of it, I'm just going to roll this a couple of times. So the left ear is on the left side. And I'm going to do the same thing on the right. With a new clean swab, I'm going to go to the right ear. And I'm going to wipe just on the external ear canal very gently. And get a nice sample. Yeah, shake it out. And on that same slide, on the right hand side, I'm going to roll this sample. Good boy, Austin, thank you. And next, what I need to do is I'm going to stain this. Actually, first I'm going to set it with a lighter. A little bit of heat will help fix the cells that are on there and also help with the earwax. There's a lot of earwax on there as well. It'll help get rid of it. So next I'm going to stain it, and I'm going to dip it in my stains for about 10 seconds each. The first one is a fixing agent, so it'll, again, just like the heating agent, will help keep the keep the cells there. A little bit. So once that is set for about 10 seconds, I'm going to blot it on my paper towel, and I'm going to go to the next agent. This is a staining agent, so it will help stain the cells so that I can see them under microscope evaluation. Another 10 seconds. And this one. Again, we're going to blot that to keep any excess staining from entering into our next stain. And again, about 10 seconds in our last stain. Blotting to get some of the excess off. And I'm going to also wipe it to get the excess stain off of the back of the slide. So now I'm going to let that sit for a little bit and air dry. So now that our sample, our ear cytology, is stained and dried, I'm going to place it under the microscope with the left ear on the left side and the right ear on the right side. I'm going to place it on our slide like so. And I'm going to start looking at it under the 4-power objective. Turn our microscope on. I'm going to take a look. I'm going to find our cells. Perfect. And I'm going to change it to the 10-power objective. And again, find our same cells. And what I'm looking for, since this is a dog sample, I'm looking for a snowman-shaped or peanut-shaped looking cell, which would show malassezia for a dog, which is the most common bacterial ear infection in a dog. Or if we're looking at a cat sample, it would be ododectes for a cat, which are the most common in feline patients. And as of right now, I'm not seeing any of that in the left ear. So I'm going to look over at the right ear. Find our sample. Because you can have an infection in one ear and not the other, which is why we take a sample from both locations. And I'm not seeing it in the right ear either. So Austin seems to not have any ear infection going on. For dermatologic and fungal testing, there's a few different methods you can use to collect hair. And what you want to do is you want broken hair and skin flakes. Those are going to be the best where your testing can show something. One method, you can use sterile hemostats to pluck some hairs around the lesion, and a lesion that you're looking for: redness of the skin, flaking of the skin, hair loss. Another method you can do to collect a sample is to use a toothbrush, and if you're rubbing the lesion area for 1 to 2 minutes, you'll collect enough hairs in the toothbrush to then press onto your medium. So what I'm going to do, I'm going to clean our area, collect it with our hemostats, and then place it on our DTM. I know, sweetheart. Have some of our hairs on our DTM. Place it. So now we'll let that incubate and see if we get anything. There has been no color change on our dermatophyte testing medium, so we'll prepare a sample using lactophenyl cotton blue to evaluate under a microscope. You can take. So the tape acts as a cover slip. I don't expect to see anything, but if we were to look for something, we'd be looking for fungal hyphae and the spores associated with the fungal. Just to confirm, I haven't seen any branching hyphae in our fungal sample. We do a skin scraping when we're looking for external parasites on a patient, and what we're looking for are lesions on that patient. We have a lesion on Austin's ear here. And so we can do a couple of different kinds of scrapings. We can do a deep scraping looking for Sarcoptes or Demodex, or we can do a superficial scraping looking for Sauroptes or Coreoptes. So we're going to do a deep scraping with a scalpel blade. So I'm going to prepare my scalpel blade. I'm actually going to put some mineral oil on a slide. Put a few drops here. I'm going to take my blade. I'm going to dip it in my oil just a little bit. And at the lesion, if we come in close here, you can see kind of on the edge of his ear here, we've got some irregular skin. And so what I'm going to do is I'm going to scrape for a deep scraping, and there's going to be some blood coming from the skin. I'm going to do a scraping there between the margin of the good skin and the not so good skin. So if we were doing a superficial scraping, I would stop there. I have a good enough sample. But since we're going for a deep scraping, I'm going to go a little bit more. You get some blood flow. There.
While looking at Austin's ear skin scraping under 100 power on the microscope here, I don't see anything worth really noting. I see a lot of hair debris and dirt debris and some epithelial cells, but no signs of any Demodex or Sarcoptes of any sort. So in order to perform a necropsy, we're wearing our protective equipment in our gear. We have our instruments and our biopsy jars. So we're going to set those aside, that way they're not in our way. The reason to perform a necropsy is to diagnose a cause of death. This patient was brought in by a Good Samaritan already passed away. We don't know any information on her. We don't know her signalement other than she is a young female. We checked for a microchip, did not find anything, so we believe she's a stray. So the reasons to perform a necropsy on her are to determine the cause of death, which could include toxicity, disease, metabolic, or even the GI obstruction. So we're going to first take a look externally and see if we can find anything on her body.
So we are going to look for the integument to make sure that it's intact, no evidence of ectoparasites, and peripheric lymph nodes not to be enlarged as evidence of active infection, bacterial or viral. We are going to look for trauma to make sure that the skull and the appendicular system and the skeleton in general doesn't have any evidence of broken bones. And in this particular dog, what we identified so far, there are very mild focal areas of hypotrichosis associated with bone decubital lesions that are healed and not problematic for this dog. So no evidence of trauma, no evidence of broken legs. So he doesn't seem to be hit by car.
Next we'll make our midline incision. Starting from the thoracic cavity to the abdominal. So now that we've made our incision, we'll continue with the scissors.
So this is the abdominal cavity. We are looking for the amount of liquid present in the abdominal cavity. Not an excessive amount of fluid, no evidence of foreign objects or evidence of purulent accumulation. We evaluate the digestive system first, starting with the stomach that feels empty, so this dog doesn't have any food in the stomach or the intestine, but also his body condition score is not too depreciated to assume that he died from malnutrition, and it seems like there's no clear evidence of hemorrhage or punctures or penetration of the GI, and the mild changes that we see at the margins of the liver lobes, no evidence of hepatomegaly or ecchymosis or any other type of lesions. There's no gross evidence of cause of death based on the abdominal cavity. So we are going to go next to look at the thoracic cavity that might provide additional information. So first we're going to make an incision open the thoracic cavity. The lungs, for sure, they have changes, and they seem to be a little bit ill-defined and diffuse pattern rather than what we expect to see, the nice pink color. So this pigmentation might be consistent with inhaling fumes or it's a pathological process. So sampling and sending to the lab would be beneficial to clarify those questions that we have about the airway. So probably at this point we don't see, besides the lung changes, we don't see any other significant macroscopical evidence of a cause of death. So the next step would be to take some
biopsy of the lung tissue, and we'll send that off to the lab for processing.
We might also take a sample of the liver and kidneys to see if a systemic disease can be associated with the lung changes that we came across. And the representative sample from the lungs from left diaphragmatic lung lobe, and from the right middle lung lobe. On the, okay, so
Left and right.
okay. We're gonna also take a sample of the left main liver lobe. Okay. Heart.
So heart, lungs, left and right, and our liver.
Next.
So we can place this in our formalin jar. So that is ready to go, and we can properly label it. Since we don't have a name of this dog, we are calling her Bucket. So I'll label it with her name, where it's coming from, Animal Dental Clinic, that it's the heart, and that we've painted it red for identification. And that is an example of preparing a biopsy sample. When it comes to rabies, those who should be handling suspects include veterinarians and technicians who have been pre-immunized to rabies. The protective gear that they should be wearing at the time of handling rabies suspect patients include goggles, a protective mask, gloves, an apron made of plastic or rubber material, and if they're working with large animals, it should also be wearing boots and a protective shield. What specimens should be submitted to the lab? And here in California, it's the public health laboratory, include the brain and the brainstem. Euthanasia should not happen in a traumatic way that will affect either of these structures. That way the lab can identify any anatomical parts as needed. The way that these samples should be stored here in California is they need to be refrigerated up until delivery to the lab. They should not be frozen, and they should not be fixed chemically in any way, as this could delay the laboratory results. They should also be wrapped in several layers of paper and then sealed in a bag with the form for submitting to the lab, and then sealed in a second bag on top of that. The remainder of the body should be disposed usually by incineration. It can be taken to a crematorium for pets specifically, or it can also be buried as long as there's lime buried on top, placed on top of the body. That way scavengers are discouraged from digging up the remainder of the body. The goal of vaginal cytology is to collect cells from the vaginal wall so that we can detect what stage of estrus our female is in. So the process of this is we have some sterile cotton swabs, some sterile saline. I'm going to moisten the swabs after cleaning her vulva. Moisten the swabs so that we don't damage any of the cells. Once we collect our sample, we'll then roll it onto a glass slide. So let's clean and see what we can get. Oh, Ellie, Ellie, Ellie. I'm going to clean with some Chlorohex solution. Oh, I know that's cold. Now the goal, the angle to insert our cotton swab is going to be a pretty steep angle straight up in, and then as we get in we can adjust it to be more level. Sorry. Okay, so now that we have our sample, I'm going to roll it onto our slide. We're going to stain our vaginal cytology slide, and the way that we do it, we place it in our solutions, our diff quick solutions, for 10 seconds each. We have our fixative and 2 stains, so I'm going to start that. I'm going to rinse it off with some distilled water. As I look at our vaginal cytology slide, what I see is a number of non-cornified squamous epithelial cells. I see a number of them in small and intermediate forms, along with a few parabasal cells scattered here and there. So what I can confirm from this slide is that our female patient is in most likely anestrus. Since there is no recent history of proestrus, I don't think she's in metestrus. The first stage of estrus is anestrus, and with this stage we see no vulvular swelling, no discharge, and the female is not attracting a male whatsoever. At a cellular level, we do see non-cornified squamous epithelial cells of different variations in size. We see a lot of parabasal cells, we see small and large intermediate cells. The second stage of estrus is proestrus, and at this stage there is swelling of the vulva and reddish discharge coming from the vulva. The female is attracting males but is not accepting at this time. At a cellular level, we do see some morphological changes to the in the cells, and a high number of erythrocytes and parabasal cells are present in the beginning of proestrus. As proestrus continues, we see a shift of a decrease in erythrocytes, and epithelial cells will begin to show some cornification. Intermediate cells are present with pycnotic nuclei. The third stage of estrus is estrus, and at this point the vulva is still swollen. There is a pinkish straw discolor coming from the vulva, and the female is accepting of the males at this time. At a cellular level, all of the squamous epithelial cells have been cornified and are anuclear or without a nuclei. A small number of erythrocytes may be present, and the number of neutrophils is very low. There should be none at this stage. At the end of this stage, the neutrophil number will increase gradually or rapidly, as a matter of fact, and the erythrocyte number will continue to decline at this point. Metestrus is the final stage of estrus. And this is actually difficult to distinguish from anestrus. Cytologically, they're very similar. The swelling and discharge have decreased and eventually will stop. The female is no longer attracting or accepting of males. And then at a cellular level, the non-cornified squamous epithelial cells will return in abundance, and there is a high number of cytologic debris. I'm going to perform a manual cross-matching for blood transfusion on 2 patients. I have already drawn the samples from each of them. So I have blood in an EDTA lavender top tube, one for the donor and one for the recipient. And I also have blood for the donor and recipient in the tiger top with the serum separator. So I'm going to spin these down in the centrifuge before I take the next step. Now that I've centrifuged my samples, I can separate them into the different tubes. So I'm going to take the serum from the tiger top tubes and I'm going to place them in a plain top, which is actually a white top tube for us. It has no additive. So I'm going to take the serum from each of the clotted samples. I'm just going to pipette all of that out. I'm going to place it in this plain tube. And then for my other samples, I'm going to take the serum off of it, and I'm gonna decant it out and use the pipette for that too. So all that's left in here is the blood erythrocyte. I'm going to do that for both my recipient and my donor samples. So now that I've decanted the plasma off of my EDTA tube, I'm going to begin the washing process. And so what I need to for that is I'm going to take 2 drops of the blood that's left in here, and I'm going to place it in a plain top tube, a white top. And with that, I'm going to then wash it using some saline. Let's put 2 drops. Perfect. So I'm going to fill the rest of it with saline. And I've already done that with my other sample from my other patient. So now I'm going to take these and I'm going to centrifuge them to wash them, and then I'm going to repeat that. I'm going to take off the supernatant, excuse me, and I'm going to repeat the process 2 more times. So now that I've washed my red blood cells with the 0.9% sodium chloride solution, I can now create a 2% erythrocyte cell suspension, which I have already done with my recipient's red blood cells. So now I'm going to perform that with my donor's blood cells. So what I'm going to do is I'm going to take 0.02 mLs of the red blood cells, and I am going to add that to a new clean tube. Oh no, 0.2. There we go. And
And to make the cell suspension, I'm going to add 0.98 milliliters of saline to the tube as well. Mix it up. And there is my 2% erythrocyte cell suspension. So now that I have both serum and a 2% erythrocyte cell suspension for both my donor and my recipient, I'm ready to do my cross-matching. So I'm going to start with the major cross-matching. And for the major one, I'm going to take my donor serum and I'm going to mix it with my recipient erythrocyte suspension. So my donor serum, I'm going to take 2 drops of each. Now my recipient cell suspension. So there is my major cross-matching. Now my minor cross-matching. I'm going to take the recipient serum and mix it with the donor red blood cells. So here's my recipient serum. Which, just as a note, was pretty lipemic. My donor erythrocytes. 1 and 2 drops of each. So now those are ready. And to check for any auto-agglutination, just in case, I'm going to do a control for both, one for the recipient and one for the donor. So recipient serum and recipient erythrocyte suspension, and donor serum and donor erythrocyte suspension. So this is my recipient control. So again, it's just like the others, 2 drops of each. So that is my recipient control. Now for my donor control. Now my donor erythrocyte solution. So now that I have all 4 of those, I'm just going to shake them up a little bit, mix them, and they're actually going to incubate at room temperature for 30 minutes. So now that my cross matches and my controls have been incubating for about 30 minutes at room temperature, I'm going to centrifuge them at 3,400 RPM and for about 1 minute. So now that I've centrifuged my major and minor cross matching for the blood test, taking a look at it, I don't see any evidence of agglutination. So now I'm going to look at my controls for each of my patients, my donor and my recipient. And everything looks to be in order. So now I'm going to take a look under the microscope. So I've created a slide for each of my cross-matching. I'm currently looking at my major cross-matching sample under the microscope, and I don't see any signs of any agglutination, which is good. Nope, no low or agglutination. So I'm going to take a quick look at my minor. See this guy? And again, I don't see any evidence, no evidence of agglutination on either of the sides, so Turtle and Austin are free to donate to each other.